Now, it's important we say, I'm Dr. Jonas Ferreira, Dr. Marcius Vinicius. Dr. Marcius Vinicius is a great professor in Brazil. He organized several masters of bone guide regeneration, have a lot of experience, and you could think about this. Dr. Marcius, all the week stay with surgeries in bone guide regeneration and other surgeries. He had much experience. And now, in Sormani Institute in Fortaleza, in ICEL. ICEL is Instituto de Estudos Odontológicos, and ICEL is very important because there we do the course of bone guide regeneration. I was thinking about this course. It's a hard course to organize because we have a problem with the patients. Think about, I have a patient, and this patient needs a surgery now to bone guide regeneration. But I said to the patient, okay, we will do your surgery, but it will be in August next year. And the patient think, oh my God, I need the surgery now. This is the problem with this kind of course, bone guide regeneration. You have the patients, you have to searching for many patients because some patients will accept and wait for the course. Another patients no. This is a problem because we have this course one time per year because we have to searching for a lot of patients. Doctor told me how was the course and how many patients each student will do in this course.
Morning, Jonas. Morning for us, from Brazil, but I think it's evening on Australia, I think. So thank you very much to invite me. First of all, let me introduce myself. I'm Marcius. I'm a professor. I'm formed in implantology and periodontology. I perform just surgeries, okay, and a lot of surgeries like guide bone augmentation and soft tissue augmentation, implants, zygomatic implants, and atrophic maxilla rehabilitation. So the problem with this course is like Jonas was told is the patient selection, because I think in Brazil it's easy but hard to find these patients because this kind of surgeries, guys, is very expensive surgeries, and so these patients cannot pay these surgeries. So this is why we are performing to both kinds of types of guide bone regeneration, like GBR and Khoury techniques, or Khoury plates, to get more patients and less cost, less money to the patients to pay to this course. So yeah, it's very hard, but we're gonna find these patients. We have these patients. So we performed maybe 6 months ago with a student from Australia. He performed guide bone regeneration, he performed soft tissue augmentations, and performed zygomatic implants too. So yeah, we have this patient, but it's not easy to find these patients. But yeah, we have these patients right now, but we're gonna wait for our course.
Okay, one colleague tell me about the sinus lift. If we have the sinus lift in this course, I said yes.
Yes, of course, yeah. We perform a lot of sinus lift here, but first of all, with the advances of implantology, we're performing less sinus lift. But yeah, you should learn sinus lift, because right now we have ossification, we have atraumatic sinus lift. So we're gonna learn all these techniques. So the classic sinus lift with caudal window opening, and we're gonna perform Summers like a traumatic sinus lift and also densification sinus lift. So yes, we're gonna have sinus lift surgeries, and you're gonna perform maybe all these 3 types of sinus lift augmentations.
Okay, and let's go to your presentation. What do you prepare to us?
So I prepared a little bit of warm-up for our surgeries and our presentation on Brazil. So I'm going to discuss a little tricks and tips for all surgeries. So not only on GBR, but on soft tissue augmentation, okay? So my friends, let's start. I'm going to talk a little bit of hard and soft tissue augmentation. But yes, it's not an easy surgery, but it's a daily surgery because we know our patients are going to lose teeth. So the first of all, you need to make analysis of your defect. So the defects are going to be small, medium, or hard. But these defects maybe have a planning first, like this case. We have this case with no bone, but you have to choose and select your patient, what surgery you're going to perform. Because like this patient, you don't have bone enough to grow bone. You need to first of all, you need to have bone to put bone there, to grow bone. On this case, we don't have medullary, you just have cortical bone. So you don't have vascularization enough to have bone. So in a lot of cases, we're going to stop our thinking to GBR, like GBR or Khoury, etc. When I talk GBR, guys, we're going to pick Khoury plates together, because in my thoughts, we are performing Khoury like a GBR, because Khoury technique use plates, okay? The plates for me is like a membrane or barrier, but because you're gonna use sparklate bone inside of the box, okay? So in this case, we don't have bone enough. We can perform a GBR or a bone augmentation, but you have to think what the quality of the bone, because you're gonna have less vascularization, you're going to have just periosteum and a little bit of vascularization of the recipient side, okay? So I like to perform my planning on softwares. This is an old software, okay? But we started here, putting the teeth first, so to imagine or to plan where my implant is going outside. So I put my implant here, and I know, yes, I have to perform a bone augmentation. So I can perform bone augmentation simultaneously with my implant placement. So I can reduce my surgeries. So I changed my program. So the first of all, you have, guys, to how to plan your cases, okay? So in this case, I had to add a bone defect here, but simultaneously I can put my implant guided or not, but I prefer in static zones to put guided implant placement with soft or hard augmentation. So the planning, we have to think and question ourselves: is available tissue volume, or we have a dental agenesis or traumas or post-extraction of alveolar remodeling? We have to planning first. So we have alveolar remodeling. We have a lot of articles. We have a lot of books showing with when we extract the tooth, we're gonna remove the tooth, we're gonna lose the bone. So we can perform automatic teeth extraction, but not of all cases we can perform as this automatic extraction. So we're gonna remodel in time. We're gonna type of prosthesis this patients use it, or the individual anatomic variations. So in this case, look at the side of defect. So we look this case, yeah, we have a problem here. with a vertical defect, 3D problem, a soft and hard tissue problem. So when I open, I have a problem. I have an implant here with a gauze. When the guys perform the implant, they put a gauze and forget the gauze on the recipient side. So the gauze are infected, and yeah, we have a lot of a lot of bone remodeling and resorption. So we have to choose correctly what kind of barrier or the barrier or the maintenance of the space. So in this case, we have a 3D vertical and horizontal problem. We have a performer with hard architecture to maintain the space, okay? So you use a barrier with a titanium mesh together. So we have problems, especially in maxilla, with a more problem in maxilla. So the problem we're gonna have more in maxilla. And in mandible and jaw, we're gonna have less problem, but we're gonna have more horizontal resorption. So when you remove a tooth, we're gonna resorb maybe 4 to 45 millimeters of this bone. So it's a lot. So in a lot of cases, you cannot put your implants in the prosthetic ideal position. So the defects. So you have three-dimensional defects, especially on aesthetic zone. So we have problems with bone. We can perform a hard tissue augmentation, but to implant with guided implant placement in the ideal prosthetic placement. And you can perform with also densification to not remove the bone and you get less resorption. Okay? And you have soft tissue problems. So I think the main problem with the implantologists in Brazil, because they don't know how to manipulate soft tissue. So in Brazil, we have a high demanded patients. So we're not putting teeth. We have put teeth with tissues. It's not only about the teeth. We have to have tissues covering these teeth. So the problem is the guys is not know nothing about periodontology. So the most of techniques with implant soft tissue manipulations came from periodontology. So the guys now is searching for masterclass courses to perform, how to perform, and know how to perform this soft tissue manipulation, soft tissue augmentation around teeth and implants. So it's easy. I not do a lot of vertical relesion incisions or open mouth the flaps. I have the volume problem. My implant is the good placement. So I have just a volume problem. So I just perform supraperiosteal incision and put matrix. This is a fiber guide matrix to get volume. And I put again my prosthetics. So, but you have combined problems. This is no more challenging, these problems. So in this case, is a cleft and lip patient. We have a soft tissue problem with nasal perforation and fistula. And we have, of course, is a hard ridge defect. So I have to close the fistula. I have to perform a guide bone augmentation, and I have perform a soft tissue augmentation, and I have to put a teeth there. So, but where is the bone to grow the bone? This is the main problem. So I say to my students, yeah, we perform a lot of guide bone augmentation, but some professors never perform a guided augmentation with this kind of patients because they don't have tissue, they don't have bone, and they don't have maybe soft tissue to manipulate, you know? So it's hard to get the primary close. So it's the main problem of this patient. We have a lot of opening post-op. So we have we lose a lot of surgeries to increase our knowledge to how to grow bone in this kind of patients. So you have to see our clinical conditions. We have adequate bone and soft tissue volume. We have adequate bone but deficient soft tissue, or we have deficient hard and soft tissues. So this question is the main question. Is it possible to install the implant in the opposite three-dimensional position despite the existing deficiency? So yes, we can put our implant and do a simultaneous approach. So implant installation with tissue reconstruction. No, you're gonna perform previous bone reconstruction. You're gonna have a better predictability. So where I can find this answer at the program with the planning of the surgery. This is how is very important to perform the planning on the software, because it's very hard to, in the middle of the surgery, you're gonna tell the patient, so my friend, I have to put a membrane here. So we're gonna pay more 1,000 reals. This is ridiculous, you know? It's not for a high level surgery. So you have to plan in first at the software to not have problems in the middle of the surgery. So we have ways. In these ways, this is the maybe our ingredients to achieve our objectives. So good implant with a good ideal position, good soft tissue volume, good bone, and autogenous bone. So this is our main ingredients. If you're gonna use xenograft, we're gonna use synthetic grafts, but we're gonna use autogenous graft because we have growth factors, and these growth factors are gonna be important to have a quality improvement of our bone. So, like this case, I planned first the install of these two implants, and I saw I can perform a simultaneous approach. So we made a guide. So we planned it first. We put the guide, install the two stromal implants. So at the planning, I saw, I can put my implant, but I'm gonna have a fenestration or implant exposure. So in the after the implant placement, I perform a guided bone regeneration. I mixture with bios and autogenous bone. The proportion we're gonna discuss after. And put a bioguide and stabilize the bioguide. The problem with most of guided bone regeneration is the problem is the movimentation of the graft. So in the course we're gonna discuss, we're gonna talk about how you fix your dispositive, and you have the primary closure of the wound. So we're gonna have vertical and horizontal augmentation techniques. So we're gonna, the old bone blocks, yeah, they work well, but we have some kind of resorption with, you don't how to manage your bone blocks. And we have the GBR, the mix, and split crest. When I say mix, is the mixture with GBR and Khoury, okay? So these gains is gonna be unilaterals, bilaterals, and trilaterals. So this article from Isawa, and he shows us the problem of the resorption. So we're gonna lose the reach in vertical a little bit, but the main problem is horizontal. So the horizontal problem is not a problem for us because it's a easy how to perform a GBR to increase horizontal bone. But the problem is the vertical, because the vertical, you're gonna have more manipulation, more stabilization is needed, and you're gonna have bone. You must have bone peaks in mesial and distal. Okay. So we have unilateral problems, bilateral problems. This is the problem of the bone blocks, because the most of the surgeries performing bone blocks, we're gonna fix the bone blocks on the buccal aspect. So if you don't plan it, this case in the software, yeah, I'm gonna perform my bone blocks. I'll augment the bone on the buccal aspect, but you have problem in the palatal aspect. So it's not possible to install the implant. So we're going to perform a second bone augmentation. This is, I think, GBR and Khoury works better because you're going to perform bilateral augmentation in palatal or lingual aspect in the buccal aspect. This is a main problem of the bone blocks. And you have trilaterals. We're going to have a loss of a little bit of bone peaks. Remember that bone peaks is the main objective and the main guide of our bone procedure. And we are proposing this kind of quadrilateral approach when you don't have buccal or palatal or top and lower bone. Yeah, this is like cleft and lip patient, because this kind of patients just have bone on the mesial and the distal. This is it. So this is enough for us. But is the problem, because you're gonna have a lot of problems of bone, the graft movimentation. So I told to you guys, just needed mesial and distal. Yeah, but it's very hard to perform guide bone augmentation on this kind of patients. So we are trying to make a new classification with this kind of patients. Like this case, see, you have fistula, don't have bone here, don't have bone here, not on the buccal, on the palatal, and just have bone at the mesial and have bone, a little bit of bone on distal. Yeah, and it's not a lot of money. Okay, guys. Another view. So look, is a thin bone. Okay, it's very small peak. This is good, but yeah, if you lose this peak, yeah, you have a lot of trouble. Okay, so this is the main ingredients for our augmentation: materials, membranes or barriers, the stability, and biological viability. I'm gonna end my presentation with a little bit of hard case. So this is a quadrilateral problem with a cleft and lip patient. So we have a fistula here, and we just have bone distal and mesial. we remove bone block from the chin and we split the block. So the Khoury technique, the original Khoury technique, use screws to fix the plates on the ridge, but you don't have the ridge. So we use the osteosynthesis plate to fix the plates on the osteosynthesis with a box, and we fill this box with a particulated autogenous graft. So we have a plate on the buccal, we have a plate on the palatal. We graft with autogenous. We drop a little bit of IPRF to coagulate, okay, to have more stability. And we put just 3 membranes of PRF on the nasal aspect to prevent a little bit of fistula or contamination, because we close the fistula, but we can have a little bit of R passing from the fistula because it is a communication from the nose. We put a membrane and then we close. We waited 4 months and we have this bone. It's a bleeding bone. It's a vital bone. We have a little bit resorption, but we have the plate here. But yes, we have a good bone, and it's a bone, it's a live bone, you know? This is why we need autogenous graft. Mix it or only autogenous graft, okay? But we have to mix, or we can use just autogenous graft. So we place implant on the ideal position. And yes, this is another case, but we're going to show at the course. Yeah, Jonas? And this is it, my friends.
Okay. Well, I love this presentation. I think it's very good to the people who can imagine the course, imagine what they can expect in Brazil during the course with you. Marcio, congratulations. I know you have so many cases and much experience. And I would like the people to know about this and come to Brazil. The next course will be in October. And we have 2 last places. I hope you can enjoy with us. In this course, it will be 5 days. The first day is in laboratory and theory, and another 4 days, it will be in surgery, on the morning, on the afternoon. The students will practice in couples, and you will be a principal performance operator in one surgery for the morning, and in the afternoon, you will be the assistant. Then you have much work to do, and I hope you can enjoy this course and learn so much. You have to talk to us as soon as possible, because we are finished the group. And okay, Marcius, thank you so much for your presentation. If you want to say something now.
First, I'm gonna have to thanks Jonas for inviting me, and Jonas to the organization for all the course, and they invited us to work together. And we're gonna thanks for our students. We're gonna have with us is August, yeah, Jonas?
August,
yeah. In
yes.
August in Fortaleza with us. We're gonna perform a lot of surgeries. We're gonna perform a sinus lift, augmentation. We're going to perform an immediate implant placement in aesthetic zone. We're going to perform GBR, vertical and horizontal GBR. We're going to perform Khoury augmentation with plates. In soft tissue like a root coverage. And just tell to us what you're deficient and what you want to have to learn. And we're going to teach you guys.
Okay. Thank you so much. And tomorrow we have Dr. Sormani here with us.
Opa, alguém entrou.
We have Dr. Sormani on the morning in the first presentation. He will talk about the AON4, zygomatic, and basic implants. I hope you enjoy it so much. And after this, I will tell you how you can make money with the surgeries of implants and bone guide regeneration. In Brazil, we have a very good technique, a very good system to do this. And I hope teach you tomorrow how you can improve your benefits in your clinical with this kind of system. Okay? Thank you so much. And we will remark the Julius presentation because he can't stay with us today. But shortly, I will inform you the next date. Thank you so much. Bye-bye.
Bye, my friends.